Hey everyone, this is Dr. Ken Sharlin. I want to talk with you today a little bit about Alzheimer's disease and the recent approval of a drug called Aducanumab, or Aduhelm by trade name. This drug was approved June 7th, 2021. It was all over the news. This has been somewhat controversial. We may not really have time to talk a lot about the controversies surrounding this drug, which I believe ultimately is a very positive thing for the treatment of those affected by early Alzheimer's disease and for the future development of treatments for Alzheimer's disease. But again, we'll touch on this just a little bit. I just want to give you a few of the highlights and encourage you to put some questions below this video so that throughout the coming days, I can try to answer them for you. A little bit of background before we get into Aducanumab or Aduhelm. And I'm going to share my screen here so you can see a couple of slides. This is from a talk that I've given around the country about Alzheimer's disease, and I think it will be very helpful. Let's see if I can get the slides to change. Okay. Not sure why they are not changing. Let's see. Just going slow. A lot of folks have trouble with the difference between dementia and Alzheimer's disease. So it's important to remember that dementia is a broad term. It encompasses Alzheimer's disease, but there are other forms of dementia, such as vascular dementia, Lewy body dementia, frontotemporal dementia. So bear in mind, as we talk about conditions that affect what we broadly call cognitive functioning, which includes memory decline, but also includes changes in reasoning or judgment, attention and processing of information, visual spatial skills, language, that all of these areas or cognitive domains can be affected. Importantly, the definition of dementia requires the involvement of at least two cognitive domains. Now, a lot of folks are concerned about having mild memory loss, and there can be a change in memory that, for the most part, only you are aware of. You just don't feel like your brain's working quite as it should be. We sometimes call that subjective cognitive decline. But mild cognitive impairment is at least severe enough that other people do notice that there's a problem, and it can be more objectively measured in tests such as the Montreal Cognitive Assessment or the mini mental status examination. These are simple pen and paper tests that can be done in your doctor's office. They generally take 5 to 10 minutes and can give us an idea if there is a problem with the areas of the different cognitive domains, including memory. But importantly, when memory is affected, this is called mild cognitive impairment amnestic subtype. And the reality here is that this is really part of a spectrum that can ultimately evolve into what we call the clinical expression of Alzheimer's disease at about a rate of 10 to 15% of people affected by MCI per year. Ultimately, at 5 years, at least half of the people affected by mild cognitive impairment will develop Alzheimer's disease, and 90% or more will develop Alzheimer's disease within 10 years of the diagnosis or onset of mild cognitive impairment. So Up until recently, the definition of Alzheimer's disease has been somewhat antiquated. There actually is a somewhat more updated definition than what I'm showing you here, but we're going to go to the most current definition in just a moment. And the point here is that for the most part, in doctors' offices, including neurologists' offices around the country, for the most part, they've been utilizing a clinical definition of Alzheimer's disease based on symptoms. We still have a lot of people who believe that Alzheimer's disease cannot be definitively diagnosed, actually died, it's looked at under the microscope. This is actually not true at all. But what's happened is that there have been a lot of people in my personal experience who go to the doctor complaining of memory difficulties, have either a MoCA, that Montreal Cognitive Assessment, or mini mental status examination, have somewhat of a low score. They're basically told, well, you probably have Alzheimer's disease. Doesn't really matter if we do any additional testing because, quote, there's nothing we can do about it. And up till this point, up till June 7th, there really only been 2 medications that were available for treatment of Alzheimer's disease. And these really only modestly improve symptoms without affecting the underlying disease. So these drugs, such as donepezil or Aricept, which is called a cholinesterase inhibitor, and memantine are really just band-aids over a problem. And that's it's been very, very disconcerting and disappointing for folks that we've had such limited options. In this context, it's really important to emphasize that the evolution of Alzheimer's disease is really a 10 to 20-year process where there is a very, very long, what we call preclinical phase, where the person is absolutely cognitively normal, but in the brain, they're developing those changes that we're going to look at in a moment called amyloid and tau protein that eventually get to the point where the person is displaying some mild memory loss or mild cognitive impairment, and then eventually developing dementia, again, over 10 to 20 years. Now, here is a picture of what it looks like under the microscope, where we see the amyloid plaques, which are composed primarily of a protein called amyloid beta 42, and the neurofibrillary tangles, which are otherwise composed of what's called tau protein. The tau protein, important to remember, although we're not going to spend a lot of time on tau today, really represent the destruction of nerve cells because they come from inside the nerve cells. They're sort of part of the train tracks that transport material from the main body of the nerve down its long arm called the axon toward the area where nerve cells connect to one another in a region called the synapse. So when you start seeing a lot of buildup of tau protein, you can think there's been quite a bit of destruction of brain tissue. Want to be able to identify the problem before there's a lot of destruction of brain tissue, because we're not going to have a lot of healing that occurs once we've lost brain. Just like getting a mammogram, you want to identify a breast cancer before it grows and spreads. We're having a lot of success in that area of medicine in saving women's lives because we're able to identify cancers early. We need to be thinking about Alzheimer's disease in the same way, that identifying this problem late is not going to be sufficient when it comes to the current available treatments, probably most likely including Aducanumab. So here's another way of looking at the same problem, where you can see at the bottom of the graph a very long preclinical phase. Tangles or tau protein really don't take off, that's the blue line, until the person starts showing evidence of cognitive impairment or very mild Alzheimer's disease, about halfway across the bottom of the graph where you can see that. And then, as you can see, that rise in the neurofibrillary tangles correlates with the loss of what they call neuronal integrity on this slide, or the destruction of nerve cells in the brain. But look at the red line also. This is the amyloid plaques, or amyloid beta 42. And you can see this very steep rise in amyloid beta 42, or amyloid plaques, that really is characteristic of those preclinical stages of Alzheimer's disease leading up to mild cognitive impairment and early Alzheimer's disease. And even when the amyloid level seems to sort of reach a relative peak and sort of flatten out, there hasn't been quite as much decline in neuronal integrity initially, and the buildup of tau protein is sort of in a moderate stage. Of course, that continues as neuronal integrity goes down. That's the green line. So in 2018, the National Institute of Aging and the Alzheimer's Association convened a consensus conference in which they redefined the diagnosis of Alzheimer's disease in the body. That's what in vivo means, by biomarkers and by postmortem exam, but not ideally, of course, not by clinical symptoms. In other words, this was a very, very upfront embracement of the definition of Alzheimer's disease by the presence of amyloid and tau proteins, recognizing that very early or very long preclinical phase before the person starts to show symptoms. And even when they're starting to show very early symptoms, we can know for sure whether or not this person actually has Alzheimer's disease. We don't have to wait until they have advanced dementia or advanced Alzheimer's disease to then make the diagnosis. And as I've shown you or alluded to, at that point in an advanced stage, we probably don't have very good treatments to intervene, at least in terms of what we would call disease-modifying therapies have to offer. So I'm going to stop this slideshow because it gets into an area that I'm very passionate about called functional medicine. But I will say that this is a way to really understand what are those drivers of Alzheimer's disease from a lifestyle and environmental perspective, and to put folks back in the driver's seat to really empower them to be able to actually take part in their care, recognize that they can do things about their condition, and that they don't simply have to surrender themselves to the doctor or the pharmaceutical company or the insurance companies and just sort of wait for a drug to do something. These drugs are very important, especially now with Aducanumab available, or at least FDA approved, and that's what I want to talk about now. So Aducanumab is what's called a monoclonal antibody. It's part of a new wave of drug development that we call biological therapy. It's like having a very, very specific key that only fits one lock. And what it does is it targets that amyloid 42 in the brain, and it helps to get rid of it. Now, there's been for a long time this idea that amyloid buildup somehow causes Alzheimer's disease, or is the cause of Alzheimer's disease, which is probably an oversimplified way of thinking about Alzheimer's disease, because we know from a lot of research that there are many reasons that amyloid could actually be quite beneficial to the health of the person, the health of the brain. It's just that we ideally want the cells to create this amyloid protein for protective purposes, and then ideally it should become soluble so that the supporting immune cells in the brain can clear out that amyloid. So we want to think of Alzheimer's disease as sort of being the last go for a cell that's trying to protect itself, and then ultimately, if it can't protect itself, sort of presses the self-destruct button, and that's when you start to see symptoms. So from that perspective, you can also imagine that if we get rid of the amyloid protein too very late in the game, where there's already been a lot of loss of nerve cells, that's not going to bring back those nerve cells. It's not going to restore memory and function. We really want to identify folks early in the game before there's been a lot of nerve cell destruction. And that's really going to be the role of aducanumab. Aducanumab is a proprietary treatment from the pharmaceutical company called Biogen. Spent many years developing this from the laboratory through clinical trials. It was approved through an accelerated process in which Biogen was given permission to skip a small scale, what we call phase 2 trial, which is kind of like a toe in the water, looking at some degree of efficacy and of course continuing to look at safety, which we'll talk about. And they went on to do 2 large-scale phase 3 trials. Now, where this got controversial is that about halfway through the trial, there was something called a futility analysis done, and it was determined that compared to placebo, that aducanumab did not appear to be actually helping with the primary outcome measures. We do know that it absolutely clears amyloid beta 42 from the brain, but the question is, if you clear amyloid beta 42 from the brain, is there going to be cognitive improvement? And the initial analysis about halfway through the study suggests that it did not, and the clinical trials were actually halted. But subsequent to that, there was a sort of a second look at the clinical trial data, and it was determined that at least in one of the 2 phase 3 trials, and in the higher dose group, that there was definitely signal that not only was aducanumab clearing the amyloid beta 42, but it was also resulting in improvement in the rate of cognitive decline across several measures. And so based on that data, Biogen kind of did a 180 and submitted to the FDA for accelerated approval based on this data. I don't need to really get into that controversy a whole lot more, but there's been a lot of sort of disagreement, some folks being very sort of pro aducanumab, and some folks connected to the FDA or advising the FDA being very against aducanumab, saying that the data was not strong enough. But ultimately, on June 7th, 2021, the FDA made a decision to approve aducanumab. And bearing in mind that Biogen, as a pharmaceutical company, really any pharmaceutical company at all, does not create policy. They may have connections to policymakers. That's what we call lobbying, of course. But they don't create policy. So we now have a package insert or an indication that says that aducanumab is indicated for the treatment of Alzheimer's disease. Now, we will see policy in the coming days and weeks and months as the payers, particularly the Center for Medicare Services, and then the private insurance companies like United Healthcare, Blue Cross Blue Shield, Kaiser, et cetera, make decisions about how they're going to cover this treatment and who are the appropriate candidates and what steps need to be taken. It's important to understand that by no means is this a cure for Alzheimer's disease, and the approach, for example, that I take in my clinic, integrating lifestyle medicine with diet and exercise, sleep optimization, removing things from the environment that can be contributing to cognitive decline, remain an extremely important piece of addressing Alzheimer's disease. And in no way does aducanumab replace those approaches. In fact, it's quite complementary, because we need to be thinking about the buildup of amyloid as really a response to inflammatory or threat signals in the cellular environment. And so if we remove amyloid, those threat or inflammatory signals are still there. Ideally, we want to remove the threat and then simultaneously or shortly thereafter remove the amyloid to protect the brain. So we're really looking at the very earliest stages of drug development in terms of what could be available to the general public for the actual treatment of underlying Alzheimer's disease. And I'm going to kind of wrap up now, but say that hopefully you can see by the information that I've shown you that it really makes sense that aducanumab should really be used for people who are at the very earliest stages of Alzheimer's disease that have biomarker evidence, meaning sufficient levels of amyloid and tau protein to meet criteria for Alzheimer's disease, but do not have a very severe cognitive decline, which would reflect a lot of nerve cell destruction, because it's very unlikely that those individuals would benefit from this treatment. This treatment is given intravenously. It's a monthly infusion. There is no end point necessarily for stopping that treatment. So once a commitment is made to aducanumab, you have to know that you're going to be getting this drug for a very long time. But that's also the case, say, for my patients who have multiple sclerosis who are on disease-modifying therapy. They don't necessarily stop their disease-modifying therapy unless it's at the direction of their physician after careful consideration as to whether their disease is either in remission or there are risks associated with ongoing treatment with an MS, one of those MS drugs. So what are the risks of aducanumab? And it turns out that generally speaking, aducanumab is very well tolerated and overall very safe. However, those receiving the highest doses of this treatment, of this monoclonal antibody in particular, are at the greatest risk for what is primarily a radiologic or imaging side effect, meaning that you may not know it's happened, but if we do an MRI, you can see it. And these are called amyloid-related imaging abnormalities, or ARIA. And there are two types of ARIA or area abnormalities. There is a swelling, or what we call vasogenic edema, around the blood vessels in the brain. And then there can be very small bleeds or microhemorrhages or deposit of the iron products of the breakdown of blood called hemosiderin in the brain, or ARIA-H. Now, it can definitely present with symptoms including headache, including nausea. We do know that it appears to be an early sign of the removal of amyloid from the brain, meaning that the longer individuals received drugs like aducanumab, the less likely that they are going to develop these ARIA abnormalities. Generally speaking, ARIA is managed by holding the drug and waiting for those changes to disappear, because again, the more amyloid is removed, the less likely ARIA will recur. There have been some case reports of more serious consequences of ARIA. To my knowledge, no one has ever died of these, but I could be mistaken. But to my knowledge, no one has ever died of these radiological findings. But that does mean that this is not a drug that you're going to be able to go to your family doctor or your internist and simply say, I want to get aducanumab. Really, there's going to be a very careful screening process. And again, I'm just speculating on policy and procedure, but there's going to be a very careful screening process. It's going to be partly dictated by the thought leaders and the scientists and the top clinicians in this area who advise organizations such as Center for Medicare Services and the private insurers. So there will be policies. You certainly have to meet biomarker criteria for Alzheimer's disease, and this will be based ultimately on either spinal fluid examination or what's called PET scan, in which we can actually use this nuclear medicine scan to identify both tau and amyloid protein in the brain. Right now, only the amyloid tracers are approved, but tau tracers do exist. So we'll at least have to utilize the amyloid protein, ideally, amyloid tracer, ideally both types of tracers. Once that patient has been thoroughly vetted, if you will, as truly having early stage Alzheimer's disease, Then, under the direction of a trained specialist such as myself, we have an infusion center at Sharlin Health and Neurology. We also have MRI on premises as a service of Sharlin Health and Neurology. We will be carefully both administering this drug and monitoring our patients for the safety and effectiveness of treatment. And I do suspect that there will be ongoing requirements to track clinical results. This is like many, many drugs. The newest drugs are always expensive. I understand the list price of Aducanumab is about $56,000 per year. Of course, there will be behind the scenes contracts with third-party payers, but nevertheless, this is not a cheap treatment. So we really have to be probably demonstrating that there is value in the treatment. And for that reason as well, the FDA mandated to Biogen that they continue studying this drug. And they basically told Biogen that if the real world experience of Aducanumab does not pan out as the clinical trials suggested, that they also have the right to pull the drug off the market. And that's not even related to sometimes occasionally we find out when a drug, goes from, being administered to say 1,500 individuals to, 1 million, 2 million individuals, we sometimes discover that there were unexpected side effects or risks that can even be serious. I'm not suggesting in any way that this will happen with Aducanumab, but we've all been surprised by past drugs, including infamously Vioxx, and even a drug that I use in my practice called Tysabri, which, by the way, happens to be a Biogen drug. But I will say, and this is for MS, that the Biogen folks have done an outstanding job of identifying the risks associated with Tysabri back when it first came out, temporarily and voluntarily taking Tysabri off the market and developing a monitoring program for Tysabri, bringing it back and really mitigating the serious risks associated with that particular MS treatment. So there is very much a commitment to making sure that this treatment is safe and efficacious. And we're going to keep you posted, but know that here at Sharlin Health and Neurology, we've been doing biomarker diagnosis of Alzheimer's disease for several years. We have a turnkey, full-service neuroscience center with clinical neurology, insurance-based third-party payers, helping to cover the costs of your evaluation and treatment. We do clinical trials here. We have the functional medicine, which is a diet and lifestyle environmental medicine approach to identifying root causes. We are exploring the value of regenerative medicine, very interested in the future role for cellular therapy in brain health. And then we have Sharlin Health Neurofitness, because movement is medicine, with our proprietary neurofitness assessment and treatment plan. And finally, we had the recent additions of both high resolution MRI and PET scan services to Sharlin Health and Neurology, as well as our infusion center. So we are truly a one-stop shop, and we want to make it easy for patients and for providers to be able to refer their patients to us, so that we can sort of take that baton and run with it and truly, truly take care of our patients and bring value to them. So I hope that this has all been very informative. Again, I'll be glad to come on again and take a deeper dive with you, looking at Aducanumab, looking at the actual clinical trials. But we are very, very optimistic that this is one important piece of the puzzle, not just for those suffering from Alzheimer's or Biogen, but a real victory for an entire industry that has spent well over $250 billion in unfortunately failed clinical trials, and for a society that puts the onus on pharmaceutical companies to develop new treatments. These are huge blows. And there have been pharmaceutical companies that have thrown in the towel and saying, we're not going to do this anymore. And we simply cannot accept this when we have 6.2 million people with Alzheimer's disease. So way back in the day when I was a resident at University of Virginia, and the first treatment for multiple sclerosis came out called beta seron, and it's still around, it only reduced relapse rate in multiple sclerosis by about 30%. That is not a cure for multiple sclerosis, but it's a stamp of approval. And there have been many people who've done quite well on beta seron. But the point is that, you have to sort of move the needle forward. You have to make a commitment to things that can encourage both positive outcomes for folks, as well as sort of throw the carrot to the pharmaceutical companies to say, thank you for these huge investments, because yes, we want better drugs in aducanumab. We absolutely do. But this is the first step in that process. And if we constantly have treatments that fail and are not approved, then there would be very little encouragement to continue to develop treatments. So thank you to Biogen. Thank you to all of the principal primary investigators and their support staff, to all the subjects who were part of the aducanumab trials, whether you received drug or placebo, and for those who are willing to take the first step in helping those with Alzheimer's disease. Signing off, this is Dr. Ken Sharlin. I look forward to speaking again with you soon.